Thank you, Phil. I'm going to be very brief. Jody's going to talk about the trends in health insurance. Purvi is going to talk about trying to identify the impact of a program. And one of the most creative things as a social scientist that I do, whenever I can do it, is to find the impact of policy without the luxury of experimental design. And so what Purvi is presenting and what Jay would have presented is a way of thinking about trying to identify policy impacts. And it's generally natural experiment designs, taking advantage of natural variation, and difference in difference analysis is typically the way that people will handle that. And it's one of the most challenging things to do. And when you have differing results, there's a need for replication, getting more data sets and more data sources. The declining employment rates of people with disabilities in the 90s and 2000s was a major issue. And we did lots of work replicating that with as many data sources as possible, and eventually came to some reasonable conclusions. And that's kind of where we are as a science today: replication, using as many data sources as possible, carefully looking at methods and sampling. But you'll see one side of that. Jay's slides will be available online, I believe, and their paper some of their work is published. So I'll turn it quickly over to Jody. You don't need to clap for the moderators.
Hello, I'm trying to figure out if I can advance slides. There we go. There are some restrooms, Wi-Fi. Does anyone from UNH know where the slides are? Ooh, somebody's moving it for me, look at that. All right. Great, thanks. Well, with the introduction that's been given, I feel a little anticlimactic that I'm going to be presenting trends in health insurance among workers with disabilities, but hopefully you'll find this work interesting as well, and I can leave Purvi to talk about the employment findings. Thanks for having me today. This is joint work with Anna Hill. We're looking both at trends in health insurance, and work that we're continuing right now will also look at what these trends in health insurance mean for access to care for workers with disabilities, since there has historically been a pretty big gap in difficulties accessing medical care for that group. So before I turn to our results, I think it's worth stepping back and thinking about the landscape for health insurance that existed in this country before the ACA went into effect in 2010. Public health insurance was available for many with disabilities if they were receiving SSDI, Social Security Disability Insurance, or SSI, Supplemental Security Income. Medicare was available to those receiving SSDI after a 24-month waiting period, and in a lot of states, Medicaid was available to those who received SSI. Some states had a separate application process, but in general, most people who had SSI also received Medicaid. There was other public coverage that was available through the VA or TRICARE, although that was relatively less common than insurance that came through Medicare or Medicaid. But the predominant way for accessing health insurance for people with disabilities and people generally was through an employer-sponsored arrangement. So if you had a job that offered you coverage, you could obtain health insurance that way. But that was available only for people who were working in covered occupations. So if they were in an industry that tended to not offer health insurance, if they were working part-time, if they were working sporadically, health insurance often wasn't available through an employer arrangement. And what that left for people who didn't have public health insurance or an employer-provided option was non-group coverage. That coverage tended to be prohibitively costly in many cases, and for people who had pre-existing conditions, it often wasn't available at all. And so for workers with disabilities and adults with disabilities more generally, there were really limited options available for coverage before the ACA. Starting in 2010, the ACA really changed the landscape. So immediately after the provisions went into effect, in 2010, there was a removal of pre-existing conditions limits that allowed more access to coverage. There was a removal of lifetime benefit caps, and for people with disabilities, these were pretty salient, that they had more coverage options available to them. Extended dependent care was available until age 26. Prior to the ACA, children who were covered on their parents' employer plan when they reached age 18 would no longer have access to that coverage, but the ACA extended that until age 26, which was really important for children who were aging into the work years to be able to maintain that coverage. But the real policy changes that extended access and affordability came in 2014. Medicaid expansions were available to individuals with incomes up to 138% of the federal poverty line, although those expansions only occurred in about half the states in 2014. Since then, another dozen or so states have expanded Medicaid. So in many states, Medicaid was available to the working poor, regardless of disability status, which is a real change from what was available prior to that time. And in addition, in the same year, health insurance marketplaces allowed people to access group coverage by essentially shopping online for those plans. In some states, those were state-based marketplaces. In other states, they were federally facilitated marketplaces. But it allowed people to get coverage in ways they hadn't been able to do before. In addition to that, there were premium subsidies that were available for people earning up to 400% of the federal poverty line. So this really opened up a range of health insurance options for both people with disabilities and people without disabilities. In 2014, there was also an individual mandate for people to have coverage, although our working hypothesis is that for people with disabilities, this mandate really wasn't what was driving their decision to seek coverage, that this was a group that has chronic health needs and that health insurance was something that they wanted regardless of the mandate. So I should note that Jay Kennedy, who obviously can't be here today, has done work in this area with his co-authors Lex Frieden and Liz Wood to look at trends in health insurance for adults with disabilities in general. We focused our analysis specifically on workers with disabilities for a couple of reasons. One, this is a group that may earn too much to be eligible for federal disability benefits. So SSDI and SSI have income limits related to substantial gainful activity, and beneficiaries historically have noted that they're really fearful of losing their benefits. For people who are working above that level, they likely don't have access to Medicare or Medicaid through that channel. Additionally, many workers with disabilities work in part-time or non-salaried jobs or in positions or industries that aren't included in health insurance coverage from an employer, and this is becoming potentially more important as contingent or gig jobs become more common. And so this is a group that may lack access to public benefits and may be limited in the availability of employer-sponsored coverage. And so the availability of this coverage through the marketplace or through Medicaid may have been really salient for this group. And I think it's important to note that really what happened with the ACA was that there was this delinking of health insurance and employment. So previously, there was a real strong linkage that to receive health care, the most likely way to, or health insurance, the most likely way to do that was through employment, and the ACA changed that. So we answer 3 questions. The first is, how did the share of working age adults who had health insurance change from 2001 to 2017? So we look at workers with disabilities from over this period, and we look at how many had health insurance at all. And second, we look at how the source of coverage changed among this group. So we really sought to understand, to the extent that we see changes in insurance coverage overall, what's driving those changes. And to try to benchmark what our findings mean relative to other groups, we consider those changes relative to adults with disabilities who are not working. So this is a group that's similar in disability status, but different in their work status, and then workers without disabilities. So this is a group of people who are working and may have access to employer-sponsored coverage in the same way working adults with disabilities may, but don't report having a disability. We use the National Health Interview Survey. I called it the insurance survey because clearly we had insurance on our mind, but it is the National Health Interview Survey. And we use the IPUMS version, IPUMS Health Surveys version, which offers a nice harmonized data series from 2001 to 2017 that we can follow using cross-wave consistent measures of employment, disability, and health insurance. We used a measure of employment as whether or not the person identified working for pay in the past 1 to 2 weeks. For disability status, we used an affirmative response to a question of, do you have a health condition that limits the quantity or type of work that you have? I know that there are many measures of disability. This is the one we're using for this study, in part because the National Health Interview Survey did not have we were going to use the 6-question survey from the census, but they didn't start asking that series until 2010, and so it didn't really allow us to look before the ACA. There's obviously, this measure is imperfect, but given that we're looking at employment, this is a reasonable measure of people who think that they have a barrier to work. In each year of the survey, from 2001 to 2017, we have about 1,400 workers with disabilities in each year. Among the full sample, about 10 to 15% have a disability, and we see employment rates for people with disabilities that are about 24 to 25%, and for people without disabilities, it's about 78%. So it's relatively consistent with information from other national statistics. We looked at health insurance that's at the time of the survey, so it aligns pretty closely to the measure of work, which is over the past 1 to 2 weeks. And there's obviously a myriad combination of health insurance, but we tried to look at big combinations, both for ease of presentation, but also because these are the ones that are probably most salient for the policy changes that occurred around 2010. So we looked whether or not any person had any Medicaid. So this includes Medicaid alone or in combination with any other source of coverage. We looked at those who had Medicare but didn't have Medicaid. So this is Medicare. They could have other options as well, but just not with Medicaid. If they had both Medicare and Medicaid, they would be in the any Medicaid group. We looked at coverage that was employer-sponsored, so purchased only through an employer without other coverage. And then finally, we have a catch-all category that we call other or largely privately purchased. This includes people who have privately purchased plans, which could include non-group coverage, group coverage. We also have in this category a small number of people who have other public coverage. This could be TRICARE or VA, or combinations of coverage that aren't captured above. The bulk of this group, however, really does seem to be privately purchased that we think may reflect marketplace type coverage. 5 minutes, all right. And then uninsured if none of the coverage sources. So first I want to show that this is the rate of uninsurance, and we see that there's a real decline in the share of people who are lacking health insurance coverage, and that this change really occurs after 2014. So the two lines here denote both when the ACA went into effect in 2010, between 2009 and 2010, and then the bigger policy changes with Medicaid expansions and marketplaces in 2014. I think notable is prior to 2014, we saw that uninsurance rates bounced around a bit, but really hovered between 17 and 22%. And then following the implementation of the policy changes in 2014, we saw an immediate and marked decline in the share who were uninsured from about 21% to 11%. There's a slight uptick in 2017, which could reflect just a small sample size, but it also may reflect changes that were going on with the enrollment period and other things that may have really meant that this is a change in the share uninsured, and I think it's worth tracking that going forward. So this is actually the opposite of what I just showed you, which is the share insured. And so we see sort of there was a decrease in uninsurance and there was an increase in insurance. And this is for workers with disabilities. And I show this because I want to also look at the group the non-workers with a disability, and the rates of coverage among that group are actually slightly higher, largely reflecting that they had more access to Medicare and Medicaid. Here's the line for workers without a disability. And we see that their pattern is roughly the same, and overall, all these groups have similar increases in insurance coverage following 2014. And finally, here's the group of people who are not working and didn't report having a disability. They have rates of coverage that are lower because they lack access to employment and public coverage, but we see for that group the increases in coverage that came after 2014 were actually relatively large. So among workers with disabilities who had insurance coverage, we sought to understand what types of coverage they have. Here we see that 8.7% had Medicaid coverage before the ACA went into effect. There's a slight increase by 2014, perhaps reflecting the fact that the Great Recession caused more people to seek federal disability benefits, and that could have driven some of this. But by 2017, we see a doubling relative to 2013 in the share who have Medicaid. We see a slight uptick as well in the share who have privately purchased coverage from 13 to 16%. And I mentioned earlier, there's other things in this category, but the bulk of the increase that we see here seems to be driven by privately purchased coverage. We also see a decline in the share of workers with disabilities who have who have employer-sponsored coverage. So it was about 52% had employer-sponsored coverage in 2009. It fell slightly by 2014, which might have reflected sort of a trend over time in the share of employers who are offering coverage. But by 2017, after the other ACA changes went into effect, it was down to 44%. And I'll come back to talk about why that may be. We didn't see much of a change over time in the share who had Medicare. And again, for completeness, this is the group that's uninsured that I had showed previously. So we wanted to understand really how those compositional changes that I just mentioned, the increase in Medicaid and privately purchased coverage, related to what we see for other groups. So since I have 2 minutes, I talk quickly and I never run out of time. So this is workers with disabilities. We see during this period, we looked over 3 periods, 2001 to 2009, 2010 to 2013, and then 2014 onward. We see that for workers with disabilities, there was a real change in, among those who had insurance, the share who got their coverage from an employer. The share who got from an employer fell from 69.6% to 52.1%. At the same time, there was a notable increase in Medicaid and privately purchased coverage that I mentioned earlier. Here are workers without disabilities. We see also that there is a shift away from employer-sponsored coverage, but the shift is much smaller. There was also a much higher rate of employer-sponsored coverage before the ACA went into effect for this group. And finally, non-workers with disabilities. This group had a much higher rate of Medicare and Medicaid coverage prior to the policies going into effect. Many of these were receiving federal disability benefits, and we see also that there is a shift away from employer-sponsored coverage. That said, in both absolute and relative terms, the shift away is largest for workers with disabilities. So just to summarize, and I'll talk about the implications in a second, there was a decline in uninsurance for all groups, and that's a good news story across the board. There were notable increases in coverage for Medicaid and privately purchased sources for the adults with disabilities, and other groups to a lesser extent. And there was a decline in employer-sponsored coverage that seemed to be larger for workers with disabilities than it was for other groups. I think it's really important to note here that we can't term this crowd out. So there's always interest in understanding the extent to which people substituted out of employer-provided coverage once public coverage was available. We have cross-sectional data. We can't observe what individuals did over time, and more importantly, we don't know which coverage they were eligible for. There's evidence in the literature suggesting that employers weren't reducing their offers of coverage during this period, but we really can't say at the individual level whether this was substitution. We can just say for this group that there was a change over time. But I think it's really important for workers with disabilities to understand what this might mean. So first, there was an increased availability and coverage. And the first thing is that this coverage wasn't connected to an employer and wasn't connected to disability benefits. So the extent that people were able to get coverage without accessing federal disability benefits meant that they potentially had reduced disincentives to work. So if SSDI and SSI meant that people were less likely to work, the availability of coverage from elsewhere was really important. At the same time, there may have also allowed workers who were working to potentially change their work behavior. So there could have been a reduction in full-time job lock. So to the extent that prior to the ACA, workers with disabling conditions kept working full-time so that they could keep their employer-sponsored benefits, if this allowed them to reduce from working full-time to manage their medical conditions or work at a level that they wanted to work, this actually could be important as well. And actually, in our data, we saw some change in the share who were working part-time. So among workers, we did see an uptick using the NHIS in the share who were working part-time. I don't think that's definitive, but I think it's definitely worthy of additional study. And I think most importantly, so in addition to having increased access to coverage options, there's the possibility that Medicaid coverage actually offers a better set of covered services for people with disabilities. Jack Gettins and Alexis Henry did a study about this in 2015, and they found that workers with disabilities identified that being able to access personal assistance services and durable medical equipment through Medicaid actually may allow them to have better health improvement and work more than they would have been if they were using the services provided from an employer plan that often don't cover that. So I think overall it's a good news story. It's definitely interesting to look at the shifts in coverage. With that, I will thank the NIDLR and the EPM ROTC for funding, and I will stop. Thanks. Uh-oh. All
right, great. Hi, everyone. I'm Purvi Sevak from Mathematica Policy Research. I'm going to be talking today about the Affordable Care Act, Medicaid expansions, and the employment of adults with disabilities. This is work that I've done with Jody Schimmel-Hyde, who you just heard from. Okay, so as Jody just described in detail, before the Affordable Care Act, Medicaid coverage for adults with disabilities was limited to certain groups, specifically those receiving disability benefits through the Supplemental Security Income Program, SSI. It was also available to those that were deemed medically needy, which means that they had medical expenses that exceeded their income. But starting in 2014 with the ACA, states were now allowed to offer Medicaid coverage to those with incomes up to 138% of the federal poverty level. At the end of 2014, 25 states and the District of Columbia had expanded Medicaid, and as of now, 37 states have adopted the Medicaid expansions. The last two were Utah and Idaho, which passed it in the 2018 election. It's important to note that just because a state has expanded Medicaid doesn't mean that coverage has actually been offered. One notable example is the state of Maine, which in 2017 voters voted to expand Medicaid, but the governor refused to implement it. So a new governor was elected in 2018, and she authorized implementation as of January 1st of this year. It's also important to note that all states that expanded Medicaid don't offer, there's a lot of differences across the states, so it's not the same everywhere. Okay, so how might Medicaid expansion affect the employment of adults with disabilities? Jody covered this pretty well, but I'll just mention that, Medicaid is a health insurance program. It wasn't intended to be an employment policy or an employment support. Nevertheless, for all the reasons that Jody mentioned, there are reasons to think that expansion of Medicaid or availability of Medicaid coverage could affect employment rates of people with disabilities. Specifically, Medicaid expansions are now offering coverage to the working poor. So this could have an impact on employment in either direction. It could increase employment rates of people with disabilities if it reduced barriers to work. In addition, because it delinks Medicaid coverage with SSI, it could basically reduces the attractiveness of SSI just as a source of Medicaid coverage. So it could increase employment because of this. But expansions of Medicaid could also decrease employment if it means that this public coverage allows people to leave their jobs that they were staying on for the insurance coverage, the so-called job lock. So the literature in general, there's been dozens of papers on the effect of the Medicaid expansions, and in general, they find that coverage expanded, there were improvements in access, and you saw some of this in Jody's presentation in terms of increases in coverage. But studies that have looked at employment effects have largely found no significant effects. These studies have looked at employment rates, labor force participation, job transitions into retirement, and hours worked. So these are studies that have looked at the full population, not the population of individuals with disabilities. There's one recent study by Hall and co-authors that Phil alluded to that shows a slight increase in employment rates for people with disabilities in expansion states relative to non-expansion states. Their estimated increase in employment is limited to 2017. An earlier study that they published found no impact in the earlier years after the Medicaid expansions. So how can we assess the impact of expanding Medicaid? As Andrew mentioned, we can think of the Medicaid expansions as a natural experiment, perhaps. Oftentimes when policies are implemented, they're implemented differentially across states or across local areas. And while the ACA was meant to have Medicaid expanded throughout the country, we know that some states elected to not expand Medicaid, and from a research point of view, that offers an opportunity to study what the impact of the policy change was, because you can compare outcomes in states that expanded coverage to those that did not. This is really possible only under some strong assumptions that the states that did expand Medicaid weren't different in substantive ways from the states that did expand Medicaid. And we question whether this is a reasonable assumption. So one look at the map of states that expanded Medicaid and states that did not expand Medicaid really reveals that this is sort of in general, a red state, blue state story. So these states are very different. This map shades states based on their expansion status as of 2016. The blue states are states that expanded Medicaid in 2014. The red states are states that did not expand Medicaid. The white states, I should say, that did not expand Medicaid by 2016, and we look at 2016 just because of the data that we had available when we started the study. And the white states are states that expanded Medicaid later, and also Massachusetts is shaded white, and these are states that we don't include in our analysis. A closer look at the data shows measurable ways in which expansion states differ from non-expansion states. Specifically, before the ACA, relative to non-expansion states, the states that expanded Medicaid under the ACA had lower poverty rates, higher average incomes, higher population density, a higher share that already had Medicaid coverage, and a lower share of people that were uninsured. These states had slightly higher rates of employment for people with disabilities. However, they also had slightly higher unemployment rates overall for the full adult population. These differences are important to recognize because they're likely to be correlated with employment rates in the period after the Medicaid expansions as well. So the innovation of our study is to address the fact that the group of states that did not expand Medicaid can't just be used as a comparison group in full. We know we need to have a comparison group if we want to look at the impact of the Medicaid expansions. We can't just look at the states that expanded Medicaid and observe what happens relative to the pre-ACA period, because we know that there's a lot of other things in the macroeconomy that were changing. We had an expansion from a big recession. So what we do is we take the comparison group of states that did not expand Medicaid, and we break them up into smaller geographic components. And the logic behind this is that, let's say we take a state that expanded Medicaid, like Maryland. We might not be able to find a perfect twin for Maryland that did not expand Medicaid, but if we break up Maryland into smaller units, counties perhaps, we might be able to find reasonable twins for those counties among all of the counties in the states that did not expand Medicaid. And so that's what we do. We don't use counties, we use a construct called census public use microdata areas, because that's a geographic unit, a sub-state geographic unit that's available in publicly available census data. We use the 2010 to 2017 American Community Survey, and it's not in my slides, but I should also note how we measure disability. The ACS has a 6-question series to identify functional impairments in the population. It doesn't identify everyone with disabilities. It wasn't designed to capture everyone with disabilities. Andrew and others have a number of published studies that show how well it aligns with other measures of disability. But it is nevertheless the largest sample of data that's nationally representative that covers all of the states. And the disability measure that's in there is the measure that we're used to seeing in the monthly employment reports that we'll hear about later today from Untitled. Okay, so how well do we do with trying to deconstruct these states so that we can have a good comparison sample? I'm going to illustrate a couple of examples. So this slide has 2 graphs. The first graph illustrates on the left the trends in unemployment rates in the pre-ACA period. So 2010 to 2013, the blue line is showing the unemployment rate in expansion states in the years before the Medicaid expansions. The red line is showing the unemployment rates in non-expansion states in those same years. And we can see on the left that the unemployment rate is consistently higher in expansion states relative to non-expansion states in the pre-ACA period. On the right, we plot unemployment rates, but now we do this using a reweighted sample of the PUMAs in the expansion and the non-expansion states. And we reweight them so that the geographic areas are similar in terms of their characteristics, like the unemployment rate. And we can see that after we do this statistical reweighting, the trends in the pre-ACA period are pretty much identical between the PUMAs in the expansion states and the PUMAs in the non-expansion states. I'll show you one more example. Here we're looking at the percentage of the working age population that has income under 138% of the poverty level. We look at 138% because that's the eligibility threshold for Medicaid coverage in the expansion, under the expansion. So again, on the left, we can see that the poverty rates are very different in expansion states and non-expansion states in the pre-ACA period, where non-expansion states have notably higher poverty rates compared to the expansion states. On the right, we plot the poverty rates in the statistically reweighted PUMAs in expansion and non-expansion states, and we can see that they're much more similar. So taking these reweighted sets of PUMAs, we look at individuals in the expansion and non-expansion states, and we calculate the change in the employment rate around the ACA in non-expansion PUMAs. This serves as a counterfactual of what would have been expected in the absence of the policy change. We make the same calculation in expansion PUMAs, and we use multivariate analysis to control for individual characteristics and PUMA attributes like industrial composition that might be different across the states. And so what do we find? Well, we don't find any good news, but we also don't find any bad news. What we find that's positive is that employment rates among individuals with disabilities rose in the post-ACA period across all states. This has been documented in a number of places, including the Untitled reports that we see every month. However, we don't see any significant difference in this increase in employment rates between expansion and non-expansion states. Again, in this sort of statistically reweighted expansion and non-expansion states. We thought there might be some differences across subgroups. You know, maybe it matters for men, but not for women, or it depends on how old an individual is or how many disabilities they have. So we estimated the same model on a variety of subgroups by gender, number of disabilities, educational attainment, age, and a number of pre-ACA state policy characteristics. And we didn't find significant effects on employment for any of these subgroups. So why don't we find any impact? It's possible that the Medicaid expansions did not have an impact on employment rates. The Medicaid expansions increased Medicaid coverage, they improved access, they had a number of very important positive impacts. But the program wasn't designed to affect employment. It's possible it didn't have an impact on employment. It's also possible that the expansions did have an impact on employment, but we're not picking it up in our data in our study. So one possibility is that the expansions had a positive effect in some states and a negative effect in other states, and on net, we're seeing zero impact. It's possible that the employment impacts of Medicaid coverage may take longer to materialize. This might be particularly true because of uncertainty about the ACA's possible repeal. Nevertheless, overall, any concern that people with disabilities would stop working because they now had this public option of Medicaid coverage seems to have not been borne out, at least not in the data that we have in the study that we've done. I also want to acknowledge funding from NIDLR under the EPM RRTC. And I will stop there.
Okay, I'm getting the sign we have 8 minutes for questions. I believe we have the ability for people online to ask questions. Is that true, Anna? Wave your hand. Anna's saying yes, so if people have questions, mics are here. We'll have people hand out the mic, so please raise your hand if you have a smart question. Dave Wittenberg, put down your hand. Sally.
Curious, being from Massachusetts, why, I think, Jody, in your slide you said that you excluded Massachusetts, not because it expanded Medicaid, but perhaps because it initiated something like the Affordable Care Act before?
Sure, I can address that. So the way we identify an impact in our analysis is by looking at pre and post and comparing states that had a policy change to those that didn't. And because Massachusetts had a lot of changes before the rest of the country, we really can't identify, like using them in our sample would not help us estimate the impact of the Medicaid expansions under the Affordable Care Act.
I think others have done that using earlier data on Massachusetts in particular, but we didn't. We just took states that expanded in 2014, and we could have done it a different way where we took all states at the date they expanded and looked pre-post and included some of those later expanders, but we just didn't do it for ease of looking at the same group of states in the same year. No, Colin.
Hi, Dave Stapleton. So I think there's been some earlier research that found positive effects of the ACA expansions on employment among people with disabilities. Is that right? And if so, how do you reconcile your findings with theirs?
Yeah, so that's the Jay Kennedy paper that was going to be presented. So they found a positive effect from 2013 to 17. Do you have any thoughts on how your studies may differ or whatnot?
Sure. So as I mentioned in my presentation, there is a study recently published by Jean Hall and co-authors that documents a positive impact on employment rates of people with disabilities in the states that expanded Medicaid relative to the states that did not expand Medicaid. So we've been talking with the authors of that study, trying to figure out why our results might differ. And while we haven't quite figured it all out yet, we have a couple of hypotheses. The first is the fact that we use different data. So we're using the American Community Survey. It's a very large sample. The measure of disability and the employment rates are ones that have been studied, benchmarked. It's possible that we're capturing a different population of people with disabilities than they are capturing in their study. Neither one is correct or incorrect. The ACS measure of disability has been criticized by many, but it is it's the data that we use, and they have a different data set and a different definition of disability. So that could drive a lot of the differences. A second reason that we might see differences is just differences in approaches. So as I described in our study, we don't use all of the people that live in non-expansion states as a comparison group for a counterfactual, and I think we explained pretty clearly why we would be concerned with using that full population as a comparison group. So we chose an alternative approach where we try and align the expansion and non-expansion states so that they're similar in demographic and other characteristics. It's possible that that could account for the difference. I don't think that that really is what's accounting for the difference, because Jody and I re-estimated our results where we don't do this, and we similarly found no effect. So the point estimate was a little bit larger, but we didn't find significant effects, even if we go with the more traditional difference in differences without accounting for the fact that the comparison group is very different.
Any questions online yet? Okay. Don't be afraid to ask questions, people online. Dave Wittenberg has his hand up front. Just another one. Oh, okay, go ahead. Sorry.
Hi, Chris McLaren from the Department of Labor. I was wondering, it's actually, you answered it a bit in your previous response about the matching, but I was wondering what characteristics did you match on, and also what kind of impact did that have on the overall sample size?
Sure, I can address that. So we didn't actually use matching, which we often use something called propensity score matching in these non-experimental studies. We used an approach called inverse probability weighting, which essentially gets you to the same place, but you don't actually have to match people. You just create weights that bring you to the same result. So it didn't have an impact on our sample size because we didn't have to drop any cases for not being matched. Things, individuals just got weighted higher or lower. The characteristics that we matched on, we started with a big, long list, and then we had to narrow it down to the things that we thought were most important. We used the employment rate of individuals with disabilities in the pre-ACA period, 2010 to 2013. We used the annual unemployment rates in the area for 2010, 2011, 2012, 2013. We used population density, and we may have used industrial composition. I can't remember right now if we did end up keeping that or dropping it. So it wasn't a laundry list of things. Everything else got controlled for in the regressions.
The idea was to find people. Okay, it is working. The idea was to find people that resided in similar geographic areas rather than match them on their individual characteristics. It was, if you're a person that lives in a PUMA in an expansion state, we wanted to find people and weight people in places that were similar to that person. And so it was really trying to get at PUMA level characteristics of similar geographic areas so that they were facing what we thought were similar labor market conditions. And similar to what you probably see with propensity score matching, we used standardized measures to look at how well they were balanced both before and after the policy change. Your last question was how much of a difference it made in the estimates. And I think it was about a 25% reduction in the point estimate. I think it went from about, it was insignificant, so it's sort of hard to say that, but I think magnitude-wise, it was about a 25% reduction in the point estimate when we did that matching.
Was it worth it?
Yes.
Okay.
I feel pretty strongly that our comparison group is worth it, but yeah, you're right. Is it worth it? I think methodologically and conceptually, when you look at that map, it's worth it.
Yeah, I think, so I have graduate students that are learning right now from this kind of methods, and it's always wondering, is it worth it to get the extra data and take the extra time?
Well, even if it doesn't affect the results in this case, it affects the believability of your results. So when someone says, oh, you found this, but I don't believe you because, Texas is not a good comparison for California.
Right. There's one, there's a criticism of these kinds of things with policy endogeneity, that, you're really picking up the fact that they're a very different state systematically because they chose to. And so could you, I know the answer is no, but conservative versus liberal in the Trump voting, and because you said red state versus blue state, but it really wasn't.
No, and frankly, that was actually mostly for the colors on the map.
Yeah, I know.
It was not intentional, it just actually, we did that for five-way compliance, but it worked out that way. But yeah, certainly there are differences across those states.
So red and blue is five-way compliant?
It passed our compliance check.
How about that? All right, so.
Okay, thank you so much. We have 10 minutes now for a break, and So feel free to leave the auditorium, and we will reconvene at 10:30. Thank
There
you
you
so
go.
much.
For people on the phone, we'll play music and we'll do some impressions.
It was online.
So have you thought about doing a one-shot test to say that